everyone, and welcome to this first edition of CRISP 2020, CRISP, and this is CRISP 2024. I'm going to set the agenda for the session by talking on imaging in calcium subsets. We all know the reasons why calcium. It's challenging to treat lesions which are calcific. They often pose a problem in treatment. They often lead to underdeployment of stents, malappositions, and eventually lead to major clinical events at the end of the day. So, assessment of calcium by any modality is not always accurate. Is not any non-invasive modality is not always accurate. And even in intravascular ultrasound and OCT show differences in their own identification of calcium. Of course, angiography is quite substandard in detecting the extent of calcium. When we look at calcium with respect to coronary artery disease, we look at calcium for pre-lesion preparations, post-lesion preparations, and post-stenting in terms of what would be the stent outcomes. Looking at stent lesion preparations, we look at the calcium morphology, whether it is concentric, eccentric, nodular, mixed, the severity of calcium depending upon the arc, the length, the thickness, the depth, and whether it is a nodular or non-nodular calcium. Once we do treat the calcium, we look at whether we have developed adequate fractures, we have adequate luminal gain, and whether we have debulk the nodule adequately to get a good post-dilatation area. In terms of the stent outcome, we look at the stent expansion, we look at edge dissection, we look at the plaque burden at the edges, and of course malapposition, which is quite rampant when we undertreat calcific stenosis. Looking at a few examples, both by IVUS and by OCT, of the different types of calcium. One, of course, that you see on the side is you see the concentric calcium, which is all around. Then you have eccentric calcium, which is on one side, which is seen on the OCT. How do I run this highlighter? So this is eccentric calcium, which is seen on one side, and this typically is a nodular calcium, which is seen on IVUS and on the OCT. The severity of calcium is also determined by the arc of the calcium. Here you see that the arc of calcium is about 180 degrees. Again, here this is the same arc of calcium. Here you see that the calcium is almost 360 degrees all around, as seen on IVUS and on OCT. The severity of calcium is also dependent upon the length of the lesion, and this you can see on the horizontal mode of both the IVUS and on the OCT. You can measure the length of the calcium. The calcium severity is also determined by the thickness of the calcium, and this is where OCT has a distinct advantage over intravascular ultrasound. We can actually measure the depth of the calcium, and that tells you what modality of treatment that you need to use. In terms of the thickness versus reverberations on intravascular ultrasound, when the calcium plate is thin, you get a lot of reverberations around on the outer surface of the intravascular ultrasound. When the calcium plate is quite thick, as is seen on the OCT here, you don't see those reverberations, but you see a completely blacked out area which is seen on the side of the calcium. The severity of calcium also is dependent upon the depth of the calcium. And the depth of calcium is it again determines what modality of treatment would be beneficial. When there's purely deep calcium, doing a rotablator may not be the best modality of treatment. They need to use devices like intravascular lithotripsy or ultra high pressure balloons to crack the calcium when the lesion is quite deep. Then, of course, you have the newer algorithm with the OCT, with the 2.0 system, where you have a AI detected calcium which is seen on the OCT, and the OCT run gives you the extent of calcium, the angle of calcium, and the maximal thickness at different areas. The severity of calcium is also dependent upon whether it is a nodular calcium. Nodular calciums, as you know, are much more difficult to treat, they are much more resistant to treatment, and the modalities of treatment that you use for nodular calcium are often inadequate, whether you use a rotablator or an orbital atherectomy. I'm sure Dr. Florim is going to talk on this in his talk on orbital versus rotational atherectomy in calcium. And, and we all talk about using the guide wire bias in rotational atherectomy. But I think that is more easier said than done to create a bias on a vessel and when you use such bulky devices. The nodule also can be of different morphologies. You have the pure fibrous nodule and you have a eruptive nodule where you have a mixture of thrombus along with fibrin, and that is which leads to an acute coronary syndrome and much more, again, complicates the management in these patients. How do we score? How do we know? How do we treat these lesions? You have the OCT calcium score, which is dependent upon three factors. That's the angle of the calcium arc, the thickness of the calcium, and the length of the calcium. Each of these are scored based on the basis of points, and a total score of 0 to 4 points. A calcium score of more than 3 is often associated with stent under expansion, and you need to use devices to debulk the calcium, fracture the calcium, and get an adequate result. Similarly, there is an intravascular ultrasound calcium score, dependent upon whether the length of more than 5 millimeters, calcium arc 360 degrees, calcified nodule, vessel diameter less than 3.5. If the calcium score is more than or equal to 2, again, you need to modify the lesions, because it's pretty well seen that the stent expansion is quite compromised as the calcium score increases. Post-lesion preparation, what do we look at when you do an imaging? What do we look at in calcific lesions? We look at fractures, we look at the luminal gain, and we look at whether you have achieved any significant debulking of a nodule. Because if you don't debulk a nodule or you don't crack a nodule, the stent is going to expand onto the opposite side. It's not going to break the calcium and expand uniformly. In terms of fractures, this is how a fracture looks on an OCT and on an intravascular ultrasound. You can actually see the fractures created by the debulking device or the debulking balloon. And once you have achieved these fractures, once the plate is fractured, the dilatation of the vessel is much more uniform and much more better. The luminal gain can also be determined on the basis of an IVUS or an optical coherence tomography. And once you crack the calcium and use a balloon to dilate it, you can measure the net luminal gain, and that again determines your net outcomes. Nodule debulking, you can also look at whether you have debulked the nodule adequately. This is an example of a nodule here, and this is the debulked nodule post atherectomy, where you have the part of the nodule which is shaved off, and that again improves the compliance of the vessel. So if I were to conclude, I would say that evaluation of calcium severity and modification for these two things, imaging is, I think, a fairly justified mode of treatment. Calcium volume, the thickness, the angle, length predicts stent expansion, both de novo and ISR calcified lesions. Calcium fracture is a key mechanism of good stent expansion, and calcium modification, whether using atherectomy or a lithotripsy, facilitates calcium fracture, even in thick calcium levels, and results in a good stent expansion. Thank you so much, and thank you once again.